So what are we doing? What are we learning? And how are we thinking differently about these things? Well, three main pathways have emerged in recent times. The first is a finance-based type pathway, which aims to help contain costs and manage affordability for payers. At a patient level, this may involve things like giving 3 initial treatment, such as they did with Cimzia in rheumatoid arthritis, where they gave 3 months, 3. You could call it a try before you buy type approach. And at a population level, where you might look to have price volume agreements, or to introduce utilization or expenditure caps so you don't go above a certain budget. There's performance-based agreements, which Mercedes has already touched on, outcomes-based agreements, where, again, you manage uncertainties by guaranteeing a certain type of data collection to guarantee your product claims in the real world. The coverage here is tied to outcomes or payment according to how a product performs, known as payment by results. And finally, service-based agreements, where we give added value to a health system, things like provided nurse care, patient management programs, improving adherence. All these things are ways of adding value and helping to reassure payers that we are willing to take a share of the risk. So out of these pathways, 4 key models really have emerged over recent years, and there's a few others that I'm also going to touch on today. The first is a subscription-based model, where you guarantee a certain amount of payment over a number of years for a product, and the manufacturer guarantees often unlimited access to that product for as many patients that need it. The second is the outcomes-based payment models, which we've touched on already, and Mercedes has, and we've also talked about quite a bit in this conference, and I'll give some examples too soon. But where a medicine's price is linked to the actual performance of the product in the real world, sometimes in terms of reduced hospitalizations, for example, things that you can usually measure economically and quantify in a model. There's indication and combination-based pricing. This has been very difficult to achieve, particularly if you come in with an indication on a lower price and try to increase it. This is often not something that's been successful in the past, but it's certainly something that people are looking at, particularly as we bring in new novel therapies, for example, in immunotherapy, which may have multiple uses, multiple indications. So I think there's still a place for this, but it's been very difficult to do. The way this has often been achieved recently is to come in with the highest price for the first indication, and then to discount for future indications. And then financial-based contracts, which are more simple to implement, often dealing with price volume agreements or payment caps, or just simple discounts. But you could ask the question, is this really guaranteeing the true value of your product? Would you be better off backing your product's performance in the real world and asking maybe for a little bit more? So there has been a rise in acceptance of these types of models. Speaking to a French payer recently, they said the French system was one of the first to start outcomes-based contracting. We worked on a product called Xolair in acute exacerbations of asthma, where they tied a risk-sharing agreement for looking at about 700 patients across a number of hospitals, and demonstrated reduced hospitalizations due to acute exacerbations using this product, and the product was reassessed and was able to retain the price premium that was granted to them by Haas. The system stalled for a while with changing governments, but it's now in a good place again. And one of the great things about the French system is that it's got excellent patient level data, so it's very easy to track the performance of a product in the real world. My colleague Nadia is going to talk a little bit more about the SNDS database a little bit more today. In Germany, German payers I spoke to recently also said that we will focus on the particularly important medicines whose effects can be measured relatively easily and unambiguously. So outcomes that we can generate, which actually mean something and can be quantified. They can't push complexity of measuring and classifying success or data transfer into the realms of the unquantifiable. So economically quantifiable outcomes are absolutely important. And the GBA is also calling for real-world evidence protocols at launch to allow for a reassessment a little bit further down the line. So let's look at some real examples of success. Kymriah with Novartis and Yescarta are two fantastic examples of where products have helped deal with payers' uncertainties. Firstly, the lack of data at launch and concerns around price were easy pushbacks, I think, for payers, but also for the regulatory agency, NICE. So they addressed this in three ways. One was going to the Cancer Drug Fund to ensure that there was budget available for the products. These are the first CAR-T therapies to be successfully commissioned. Secondly, they put in place a confidential discount. And thirdly, they agreed a commitment to real-world data collection, which also will involve a price reassessment as early as 2023. I think this is an excellent example of how agencies and manufacturers can work closely together to bring products to patients who really need them the most. There's three key learnings, I think, from this, from these examples. The first is the multiple stakeholder engagement, working with, in this case, the EMA, NICE, and the Cancer Drug Fund. Early dialogue and collaboration with these authorities around managed entry agreements and trying to find the right fit for the product that achieves that value demonstration that's necessary, but also backs the product's performance in the real world. And then ensuring, for example, through engagement with the Cancer Drug Fund, that funding is in place and ready to go once the products are launched. An example of how you can prepare payers and budgets for a new product launch is with Bluebird Bio's Zynteglo. They worked very closely with the German sickness funds to ensure that budgets were available come launch. And they'd already agreed managed entry agreement for the product once it was approved in market. They also put in place annuity-based payments, which could be spread over 5 years, and performance-based agreements, which link to annual payments, which relate to clinical outcomes. Three learnings from this one is that multiple types of managed entry agreements can be combined to create a single model to help address payers' uncertainties. This is why I think bringing different things to the table to these discussions is really key, and something you can do early on if you engage payers in good time. Performance-based agreements also can help satisfy the use of clinical endpoints post-marketing, and help address payers' uncertainties by looking at extrapolating and extending studies or looking at real-world data performance, and positively engaging the payers and putting these financial agreements in place early shows that you're willing to take a share of the risk. NHS England, and I'm sure everybody knows about Netflix. I'm sure everyone's been using a bit of Netflix during lockdown. I know I have. NHS England and Vertex, I think, is a great example of this in cystic fibrosis. This is a portfolio subscription-based model where you basically they get NHS guaranteed to pay £1 billion over 10 years for a product, but they would the company guaranteed access to all three products in their portfolio, so Orkambi, Simkevi, and Kalydeco. So, and there's no cap on patient numbers. So the idea was that 5,000 plus patients would receive access to these products, and the company worked to ensure there was a flexible commercial mechanism for payment that would ensure continued access to these programs. They're also working with NHS England allowed the company to circumnavigate NICE and to bring the product to market and to patients who really needed it quicker.